You do urging.
You do some quality.
Oh, out there.
Yeah, on the side here. But
How many people even know that exists? Is that
yeah,
something
the
right now? Does
volume,
it
the volume
exist?
growth would suggest that lots.
Really? Which is why they put them in, right? To save everybody from Portage.
No, my son is going up the
Portage is scary. I think people go up there and go, what are you doing? Do not do that again. Don't do that again.
Just so everyone knows, we're about to start, but we're going to have two people on Zoom. And the Zoom camera for them is sitting right over there with the little white ring. And the speakers that will give their voice are over there on the table. So we are per se one person in the Zoom meeting. Oh, it looks like we have three. Yes. Valerie, Aaron, and okay. Well. All right, then I think we can call the meeting to order at 6 o'clock. Roll call, I believe, is the three board members are present. Never figured out how meetings, if every member is like roll call. Probably should be. So, Dr. Butoff, Dr. Anderson, oh no, Phil Branham. This is hard. Sarah Dox from UW, Laura Dolman, and Sarah. You might want to turn your sound so that people can see it. It's blank. Brian, and then Jack, and Brian, and myself. So everyone we expected is here as of 6 o'clock. And we just need to approve the minutes for the meeting. Is there a motion to approve? From Jack?
Second.
Second from Dr. Anderson. And all those in favor say aye. Aye. All opposed? And our first order of business is we'll give an update on the school programs since the last meeting. And Randy?
I will take that. Thank you. First of all, I just want to thank everybody for shifting your schedules around. We initially were going to meet next week, and I think for some of our conversations offline, we were just looking to see if we could bring this closer in line with when we had our first snapshot of our 14 days of data, which was yesterday, and then also potentially then kind of shortening up any timeframes on decisions with regards to a piece in front of us tonight, which would be consideration of the reasonableness of bringing back our third and fourth grade students, which would be kind of the next progression that we would look at. I just want to take a minute to just kind of overview kind of where we're at and what we're doing as a district. First of all, since we last met, a huge thank you to Sarah, Kurt, Brian, Annie in our communications office, and all of the staff that work in our health offices. They've just done a phenomenal job as far as trying to really follow up on some of the things you're going to be learning about tonight, the contact tracing aspects, putting together the processes that we need to be continuing improving on. I'm really pleased with the work that they're doing and can't express that enough. Particularly this week, we've been quite busy. We've had some things that we've had to communicate out to parents with regards to a few COVID cases, some close contacts, and doing a lot of kind of work on their end to do that as efficiently and do it at a high level. And I think that they've been able to accomplish that. So thank yous to them as they're going to be presenting some of their work tonight. When we just take a review of what we have happening in the school district, we do have our 4K students in and our kindergarten first and second grade students continuing in their morning afternoon hybrid. We also have our special education students. We have about 80 to 90 of our students that are in our schools that are receiving some of their special education services there. From an aspect of our co-curriculars, we've had cross-country, golf, and tennis continuing. And then what's called contact time, or basically times where you can have connections between coaches and players in other sports. We've had those occur in soccer, football, volleyball, at the middle school and high school. Some of those are continuing, so if you've driven past the high school, in the middle school, and some of our other fields. You're seeing a number of kids that have been participating in those. They've been generally masked and within within the boundaries of public health as far as the pods and the groups of how they've been organized. We've also had volleyball occurring, which is a little bit more difficult because we have smaller groups we have to contain within some of our buildings. And we've continued with what we've called our strength and conditioning or our agility work with a number of, that's a carryover from our summer school program. That has continued as well. So those are some of the pieces that have been occurring out of those. I mean, certainly we've had some things that we've had to communicate with parents on. Again, like I said, a few positive COVID cases and also some close contacts. That's part of, I think, what we expected would happen as we continue to work through them, but I give our staff a lot of credit for how they've kind of handled that, tracked that, and I know as I've spoken with Brian particularly, Brian Grabarski, as they've tracked some of those things, particularly that are involving staffs, they've done a great job with just trying to kind of minimize some of the spread of that just by their practices as a staff. So I give kudos to our staff for being very cautious in the work that they do, either with students or with each other. The next pieces that we're really looking at occurring within our district is a consideration of should we be bringing back our next iteration of students, which is our 3rd and 4th grade students. We are also looking at what we've titled enhanced remote instruction, which is looking at primarily kids in our secondary level, where you have programs that are very hands-on, and seeing how can we bring small groups of kids together to be able to have those experiences that are just very difficult to do remotely. So that might be something in tech ed, it may be some of our science classes, it may be a few of our other programs that have those aspects that are just difficult for us to deliver remotely, and can we do that within a confine of some small group instruction. And then obviously the next piece that we're having questions about is how can we, as we move out of the fall and more towards the late fall and winter, what does that look like with athletics and any further kind of contacts that coaches can have with some of our students. Some of those are going to be allowed to compete at different levels, and others, because of our rules within Dane County, are relatively limited. But the contacts that we've seen with kids working in some of these programs has certainly also been a mental health lift for many of those students. So if we're able to do them safely, or safe as we're able to, those are some things we want to at least consider. So our guiding principles walking into tonight, we're obviously looking at our internal processes, our internal data, and then our community data. And that's really what we put in front of you. We emailed it out late yesterday. And we want to take some time right now to really kind of walk through those pieces for us and answer any questions that you may have. The first place that we would begin would be kind of our internal processes. And what I'm going to do is share my screen here if I can, so that, sure I grabbed the right one. There we go. Let's see, which one am I looking for? Is that it? Where are the contact tracing? There we go. So I know Kurt and Brian and Sarah, you've worked very extensively on kind of our contact tracing process. Can I just have you take some time to talk about really what's taken place since our last time we were together with regards to some of those processes? We've also are looking to add, and we're going to be interviewing Brian next week for a contact tracer and some additional nurse time. So Kurt, Brian, and Sarah, if I can have you talk through some of the processes that we've put in place since the last time we met.
I think as long as you have this document pulled up, Randy, we'll just have Sarah kind of walk through the document, because that's what she put together and is what we're really using across the district to do our contact tracing. So Sarah, you just want to kind of give us a brief walkthrough of the tool that we're using.
Sure. So in order to help be more systematic in how we're collecting data from families, when they call to report students absent with symptoms, or a close contact, or a student who has tested positive, we developed these questionnaires so that really anybody can make a phone call and collect information that will help us guide our decisions about when students can return to school. And so basically we just outline questions here. Our staff is calling and going through the questionnaire, getting pertinent data about when symptoms were developed, what symptoms were. And then, so there's a page 1 that's data collection, and then the second page is typically sort of a script for discussing when students can return to school. Tried to make it user-friendly, that that you can calculate soonest date of return, and include important information about, including the fact that their symptoms need to be improved and 24 hours fever-free before coming back to school in that first contact. So families receive a phone call and then a follow-up email that includes the returning to school after COVID-19 document that we've shared, I think, previously, as well as the public health table that you can fit, easily fit them into the category and decide how long they need to be excluded from school. So there's a script for each scenario, and it's been working fairly well. So I think that, it's a step where we're tweaking things as we find that maybe there are areas that need some refinement. But it's a good way to have a tangible tool to use and to make sure that we're consistent. And what I've advised health staff is that even though we're getting communications about symptoms or about contacts in a lot of different ways, whether that's an email from a teacher or a call to the attendance office, we have a lot of data coming in, and I'm just asking them to focus on the questionnaire. When you're making the phone call, just say to the family, I know that you may have already shared some of this information, but we're just trying to be systematic, and so I have a questionnaire, our standard questionnaire that I'd like to go through with you. So families know that, we're not trying to ask the same question a million times, but really we're just trying to compile everything and make sure that we're accurate, because we have so much information coming in from different sources that this is a way to make sure that it finds its way to the right place.
One of the things Sarah, Randy, Brian, and I met right before this meeting, and something that we're going to explore again as we continue to tweak our processes and our systems, is create some template letters, emails, basically, in Infinite Campus, so that when we do need to send that out, it just saves a little bit of time on the staff as they're putting that together, instead of having to cut and paste from one system into another system and all that. We're just trying to simplify that, and we're going to start working on that tomorrow with some of our office assistants to see how we can get those template letters, emails into our Infinite Campus system to save us a little bit of time as we generate those follow-up emails to families after we've done work through this process for a summary document that they all receive with the key dates and information in it.
How does this work if it says if date falls on a weekend? Somebody's in an activity that goes over the weekend.
Yep, so we just encountered that yesterday. And so when we initially made this script, it was when we were mostly dealing with elementary level students who we were talking about return to school. And so yesterday we realized that we probably need to have return to school and we need to have return to play. And so the end of the so we count 14 days from symptoms or 14 days from last contact, and the following day is return to play. But that was confusing for some health office assistants in terms of school. And we just needed to be clear that if it fell on the weekend, we would never go back a day and have that child come back on a Friday. We would move forward to the Monday, the weekend, or the following week. So we will be clear, we aren't rounding to the nearest week, for example, for the students who are in sports who have a tournament on the weekend.
I guess the only thing that I would add to their what Kurt and Sarah shared is that we'd also talked at this last meeting and at our school board meeting about getting a contact tracer position for the district. That position has been posted internally and also out on some web resources as well. And we've been pleased with the applicant pool we've gotten so far, and have are targeting screening and contacting the folks in that pool for interviews midweek next week to get somebody on board.
I think the conversation we had at the last school board meeting, I think, Jack, you kind of titled it, kind of like a COVID command center type piece. I would say it's not everybody in the same room, but it's definitely people working on the same page, and definitely a huge team effort. Sarah and the nursing staff and team that definitely have taken on a large part of this. Administratively out here, it's primarily Kurt, Brian, Andy Blackburn in our communications office, and myself. And I think that's kind of how that process is structured. And as we add more staff, we'll be continuing to find their places where they can conduct their work and make sure that we're all connected together. And I think that's part of what we're trying to make sure, that we have the right people in the right places who can make the decisions as we move forward. I mean, and as Sarah has shared with us, I mean, there's some of these things that are entangled. They're not all as simple and straightforward as they may seem, and so there may be places where you may need to have, even if you have somebody else contact tracing, there may need to be somebody with a little bit more of a medical background to help decipher kind of where to go, which brings in, obviously, our nurses being a key part of that. But that's the process we've really dove very deeply in, and I give these guys credit for really what they've done and the trainings that they've looked at. We're looking at continuing more training with regards to the contact tracing. Brian, you were alluding to a training through, was it Johns Hopkins that you were looking at? That's like a full day training for the contact tracing process.
Yeah, it's and credit goes to Sarah on this one. She actually found it and kind of initially did a little bit of a vetting out of it. It's a course offered through Johns Hopkins University specifically for contact tracing, and it appears to be a manageable amount of time, and looks to have some good material within it. So we're actually going to obviously use it. Going forward, use it for the new person that we hire, but we'd also had discussions about having health staff, our health office staff, get into it as well, as it could provide benefit to them in their conversations that they have with following up on students that are ill as well.
So just to give you a little bit of background, also in the memo that I sent out to the committee that was really talking about our contact tracing process. And we're feeling like we've made great progress over the last few weeks. We anticipate making continued progress and improving what we're doing. The one piece that I do have to be very open about is if there is a point where something occurs, an event occurs that kind of overwhelms our system, there may be a point where you have to just pause an activity, pause the classroom, or pause a school until you can do the contact tracing and get caught up with that. I mean, when we look at yesterday was a big day for our folks in their work. I mean, there were 20-some folks that we were following up with. That took, I think, between the point where they were starting until we actually were able to get the messages out to staff and parents, it was about 5 hours. But it was 4 or 5 people working during that time period to accomplish that. So if it was more students or shorter time periods, we're going to have to make some decisions on a short-term basis to allow for that to be done with fidelity, so that we don't create risks or cut corners within the contact tracing piece. And I know I'm talking to Sarah. That's obviously a concern for them because they are working very hard. This is pretty in-depth, intense work. We're adding some staff and improving our processes. But if something does occur where we have to just take a pause for a day to get caught up, that's a piece we just need to make sure everybody knows is potentially reality.
And I think that's consistent with what you're hearing in the news with some other schools that are closing down for a week or 2 days or whatever it is that they're determining is the time that they need to do that. So I think the approach that we're suggesting that we will take as well is consistent with what other districts are experiencing and what they're doing as far as a practice. If we get to that point where we feel that our system is over full, we may have to just take a little bit of a time out and say we can't do this, whatever this is, for a period of time until we're able to catch up and really assess the situation to know how we can proceed going forward.
With that, we open it up to the committee on any questions you have about things that we're doing with regards to our contact tracing or any of our practices that Sarah, Kurt, and Brian updated you on. Or anything that you saw within the packet with regards to the protocols that Sarah and her team have put together.
There's one thing that's really small, and you might have a process for it, but on that first page, so has a student been tested for COVID-19, yes or no? And then test result positive, negative. What would you do if the student's been tested, but the result is pending? They don't have an answer.
So all of the data that we collect here is being entered on a school-specific data tracking form. And so if there's a pending result, we mark it pending there, and the health assistant knows to follow up on that.
Gotcha. And if it's pending, what advice do you give the person you're contacting, the guardian?
So the students who have test results pending are to remain out of school until they receive their test results.
All right, cool.
Any other questions? We want to move on to the opening principles.
Yeah, and taking a look now, really the next piece is we just kind of reviewed our internal processes. The next piece is kind of looking at our data. So I'm going to, and in your packet, you're going to see a couple different things. First of all, you see our decision-making framework, which the board approved at our last meeting. It talks just about with regards to the role of this committee, administration, and the board as far as decision-making entities that help to guide reopening of schools. The second page of that has really our data dashboard or our key data elements. A little bit hard to read here, so what we included in your packet was one that's same data and just a little bit easier to read format. So Kurt's been very active in tracking all of these pieces. The first one is with regards to what's happening with our cases. This was accurate as of probably 5 o'clock yesterday.
Yes.
And I know that we've added numbers to it, but Kurt, since you kind of are populating this, and I know Sarah, you and your team are kind of the ones that are also generating this, do you want to walk through kind of what we're seeing and kind of what our internal data is looking like, Kurt?
Sure. We'll just kind of go along the top so everybody understands what the columns reflect. The first column is the number of positives, the number of staff who have had a positive test for COVID-19. As you see, because we're trying to protect the identity of students and staff, if a cell is less than 5, we're just marking that with an asterisk as we're sharing it with the public. As you can see, right now we have 5 staff who have tested positive for COVID-19. The second column is number of staff who have been identified as close contacts. And again, we're using the public health Madison-Dane County definition of close contact, which is within 6 feet for 15 minutes or more, or you had direct contact through physical contact, through the exchange of water bottle, food, etc., or you've lived with someone who has, you're living with someone who's tested positive for COVID-19 or has had close contact there. So we have 13 staff who've been identified as close contacts. And then we do the same. The next 2 columns are students who have tested positive, students who've had a close contact. We are at 3 students who are positive, 44 students, close contact. As you can see now, we're starting to get some cells that we're actually reporting true numbers for different schools. And then Sarah and the health office staff have been tracking students that have symptoms of COVID or symptoms of illness. What we're using here is, again, if you recall back to the last time we shared that chart where public health is identified, there are 12. There are 3 of them that if that is the one that you have, you are identified as being like COVID-like symptoms. And then the other ones are you have to have 2 or more. So that's what we're using to populate these fields are the students who are presenting symptoms like a sore throat, a cough, whatever the case may be. So we're monitoring those. And again, as Sarah mentioned in the contact tracing piece, making recommendations to parents to keep their children out of school until they have maybe contacted their healthcare provider, obtained a test, a COVID test, or something to that effect. And then the last 2 columns, we decided to add those. We really took the last 3 columns off of the Elmbrook School District's data dashboard, thinking that at some point in time, and we should again track if we're having to close classes or activities, we should be monitoring that as well, just so that as we get deeper into this, we can see what the impact is that we're having within the community, some of our school-based activities and classes. So that's kind of what we have in this section.
What's the time frame on this? Is this the 14 days, or is this since school opened?
This is a these are cumulative numbers. What you'll see in a minute, you want to flip to the next, the community numbers. Here we're tracking, and I have a larger spreadsheet that I'm maintaining somewhere, where I've been collecting daily data off of the Department of Health Services census tract map for the 4 tracts that make up the Waunakee School District. And that's what, you don't have this, I have it here. And I've been collecting that data since September 15th. And then what we're reporting on our dashboard is what you actually see on the screen and what you have in your packets. We are now able to track 7-day averages of positive cases, 14-day average positive cases, a burden rate on a 7-day model per 100,000, and a burden rate on a 14-day model per per 100,000, and that's the information that you see before you. And then we reported the last 5 days of our data on this one. We will be posting on our website, as well as sharing with the community and our school board, a larger snapshot of this information so that people can have it and monitor it as we continue to go on. We're looking at doing that on a weekly basis. And then Randy, do you want to talk a little bit about what you're sharing right now?
What I'm just passing out, and for some of you who probably work closer to this, these numbers mean something to you, but I needed something that was a guide that helped me to understand what exactly these counts were, these values were per 100,000, et cetera, for 7 or 14-day averages. This was actually a document that Public Health Madison-Dane County sent out, and it just shows different models, everything from the DHS to the Harvard model on the left-hand side, Milwaukee, San Francisco, different models from across the country that have looked at really what I guess we've titled kind of our burden rate or what our activity rates within the area. I think we've taken a look at kind of the Harvard piece, and I know Matt, you shared with me kind of a heat map of from the New York Times. The Harvard model actually pulls one up that's a little bit more current, but I think that's a piece I just thought you at least could see. If you look at on the left-hand side, the Harvard numbers that go across, it kind of gives you an idea of where we fall within those cases per 100,000. And I believe that theirs is over, I believe, a 7-day period. We have a little bit of both here. We've chosen to try to look at 14 days because we don't have quite as much volatility in it. One of the pieces that we saw yesterday was a jump to 10 cases in one day. We were trending from 1 to 5 on our other days. Today we're back down, Kurt, to 5.
We're at 5 today.
We're at 5 today.
5 today.
But just even one number puts a pretty big shift in some of the data. When you take a look at Dane County, we have, and this document is in front of you as well, you can see kind of what we're seeing as a county-wide piece. So if you look at your 14-day model of 100,000, they're looking at a value of 30. We were looking at a value of 18. I think our value dropped down a bit today with going down to 5. And then when I looked at, I'm just going to back out of this for a second and go up to, this is actually the metric off of the Harvard site. And when you go to, where's Dane County? You can see Dane County's date as of Monday was 23. So the 30 number was built off of that came from the Public Health Madison-Dane County for the 2-week period, September 8th to the 21st. And it was reported on the 24th, so it's already over a week old. So over the course of the time when that data was reported to this Monday, you can see kind of a trend from 30 down to 23, or at least that's how I'm reading that data piece. But I think this was a similar to Dr. Anderson, what you were sharing with me from the New York Times.
I've got a question on the data. When you look at the district data, number of students, symptoms, or illness, are those call-in? Did somebody call in that I'm not coming in because I've got these symptoms, or are you picking these up in school?
No, so we're following up on any students who are out due to illness and calling and specifically asking, what are your symptoms? So that data is being gathered that way. I will say that, as you can see, there are no cases listed for 4K, intermediate, middle school, and there are some challenges with collecting that data.
Yeah, one of the things we've talked about is as we approach opening up at other grade levels and buildings, we need to do some marketing with our parents to let them know how important it is, even if your child is in a virtual learning environment, that we get information from you. And I know there's some conversations out in our community about why does that matter? Well, it does matter. Virtual students do not live in a silo. They are intermixing with kids who are doing in-person learning. We also have siblings at high school, middle school, and the intermediate school who do have younger brothers and sisters who are coming in person in 4K kindergarten, first and second grade. And they will be when we add third grade and fourth grade and so forth up the line. So you can't just silo these things out and say this particular group, because they're virtual, doesn't have an impact on what we're doing. They absolutely do, because they're living with siblings, and they're also, if you drive around our community, you will see kids at parks. You will see them riding bikes, skateboarding, sitting at the table outside the Quick Trip. We don't know if those are virtual kids or if they're in-person kids, in that mix of kids. So we need to have the information so that we can do the follow-up procedures that we need to do to make sure that we're providing good information to this group as well as the board as we continue to make decisions, so that we understand the true scope of what is happening within our community. So we do need parents to communicate with us, whether their children are virtual learners or in-person learners.
Kurt, what have we done to ask parents to do that?
Well, we worked with our principals to communicate that out, that we need that. It's something that we will do again. I think as we do more general communications, like in Randy's updates, we need to always have that information in those communications so that parents understand that it is important for us to know. Because this is, the numbers that we're reporting here at Arboretum, Heritage, and Prairie, if you just look at those, it is a mix of in-person kids and some virtual kids who may get put on the chart because of a sibling at some other level.
It's also communicating with the teachers, because oftentimes parents will email directly to a teacher and say, my student isn't participating today because they have a cough or they have a fever, and if that data doesn't get to the health team, we can't get it on here. And so then, we need to be able to get the data in order for our numbers to be accurate.
Kurt, I believe earlier you said that this data was cumulative. Does that mean, when you're saying cumulative, is it active cases or cumulative of even students who have returned?
Right now it is cumulative. As we continue to gather information, well, some of it's cumulative and some of it is not. So this chart that Randy has up right now, that is cumulative.
That's when we opened on the 8th till now.
Correct. The
This,
community numbers
These
are, it's all to
Yeah.
the date.
so on the
It is
25th,
specific
there
to
was
the
one
date.
case.
I mean, at some point, are we going to switch or create a version that's active? Because obviously knowing
Yes.
someone had it in September and we're in November,
Yes.
we're not going to care.
What we are starting to do now on the charts, we have two sets of charts. We have one Google Sheet that is for each building, that is the close contacts and the positive tests. And we have the other one that is really maintained by the health assistants and the nurses, which is the illness, the symptoms one. What we're doing on those charts now is we are adding like cleared. So the kid is done with their quarantine or their isolation, and now they're able to participate. So we will be able to, going forward, say where we are in real time with students who are in quarantine or isolation. We will be able to do that. going forward.
But I think one of the things we discussed at our last meeting was trying to differentiate between Dane County and Waunakee. So that's part of what we were trying to articulate. I mean, our view of the data, and we're looking for some of your input into this as far as interpretation of it, is certainly that there's a level of activity within Dane County and Waunakee, but we're seeing a lesser degree of activity within our own community. So I guess, I mean, that's, I guess, a point I'd just like us to kind of, any questions the committee has on the data that's in front of you, what kind of your views on it from a medical perspective as far as what this means for us as a district, what this means from a community perspective as far as the activity that's occurring, and really as we start to then parcel into decisions and discussions about moving forward with additional grades or programs taking place of what we need to be considering or moving forward with and the reasonableness of that.
Can you speak a little bit to the close contacts? Are those close contacts predominantly occurring at school or school-related activities, or are those occurring, outside of work?
It's both. Up until this week, it was primarily outside of the school, but now this week we've had something, and that happened, and it was, it brought us now to more even. They're probably about 50-50 right now. One, Randy alluded to this, that yesterday we were doing 23 total between, 24 total between staff and students, contact tracing, and that was really due to one event. Prior to that, it's been primarily outside, the contact has happened outside of the school.
But this came from like an additional activity that had a group of those smaller groups, and we were able to identify then which kids in that smaller group were close contacts, and that was the work that they did yesterday. So that was kind of our first example of something within a school program that had impacted really making its way onto this chart.
Today we had another event, and it was a much smaller scale that was an in-school close contact.
Have you been finding people being forthcoming when you do contact tracing? Or are you having people who are hesitant to provide details once you contact them? How's that been going in our community?
So I would say that people, I have been forthcoming with that information, especially you guys have talked mostly with the people who've had the close contact on school property. Our close contact sort of contact tracing have been more family members who have tested positive, and so their child needs to quarantine. Those are a lot of the conversations that I've been having. And many of those families have already been in contact with public health. They're aware that their child needs to quarantine for that period, and there haven't been as many issues with that. And then the data that, that we've gathered with the larger, Brian and Kurt, you did sort of the initial contact tracing of that situation, and then they provided us with the close contacts to follow up on. So I don't know, how that went for you.
From a staff perspective, I would say that folks have been very open to communicate. A little bit different situation than what Kurt had shared. If we talk specifically about close contacts with staff, Randy had mentioned it earlier. I think our staff have been doing a lot of really good things to keep themselves safe and keep as many people around them safe in terms of social distancing, masking, being aware of hand hygiene, etc. So from a staff perspective, the number of close contacts that are school related, it's only a quarter of them. So 75% of the folks, this is a close contact that happened outside of school, not connected to Waunakee Community School District. But I have found staff to be very open and actually very truthful in terms of when they can identify definitively that they have been doing the right safe activities, or when they maybe brought themselves into question, they've been willing to share that openly.
I will say that one of the pieces that gets a little tricky is those events that happen outside of school, like if there was a neighborhood play date, and we've been having conversations around sort of the best way to approach that. Public health has said that, you know, we are not required to contact trace in those situations, but it gets a little tricky if you're aware that multiple families were at that play date and you know that a child should be quarantining, but you haven't yet heard that family hasn't self-reported yet. So we're working on our processes around the best way to approach that.
And to get to your question, I think a little bit about just the data. I think the key takeaway for me is that there continues to be not insignificant community spread, you know, of COVID obviously in the area. And I think that there's obviously there's recommendations and data out there about that level of community spread is tied somewhat to the success of returning to in-person school and the ability and stability of doing that. And so I think the other thing which was in your handout that you sent from public health is we're seeing a bit across the state, but in Dane County as well, where you'll see the UW numbers have gone down substantially, but we're starting to see more shift towards other age populations along with that. So I think I think that gives me a little bit of pause. I don't know that there's ever any absolutes on things, but I think there are some, you know, not insignificant risks associated with that. I think when you look at other parts of the state, you're seeing a lot more hospitalizations, you know, associated with that. We've seen small, it's hard to know if it's a blip on the radar, if it's a pattern, you know, the beginning of a trend. We've certainly seen some increases this week, not that to the point where it's difficult to manage, but it's not unnoticeable either. And so I think that, you know, curious what others think, but the lay of the land to me is still somewhat uncertain as we continue to have not insignificant spread. And so I think it's a risk. And I think that the risk comes into what's that volume going to be? What would it look like if you had an event, you know, as far as that goes? And, you know, in bringing people back, does that jeopardize your K2 in some way if you bring back somebody else? I think those are just the kinds of questions that, you know, I'm sure others have thoughts about, but I think there's still some obvious spread and risk out there.
Yeah, so I wrote down 8 things, and Matt hit on at least 3 of them that I thought of as we've talked.
Missed 5.
What's that?
I missed 5 of them.
It's still not bad.
Still not too bad.
It's like an organic test. You got
and you were certainly on the data. This is what we were there. But so one, I think, and you've addressed it a little bit, but it's the capacity to contact trace. I think with case volumes going up around the state, and we're probably going to see that happen in our area too. You'll probably have more cases to contact trace, and the more kids you have in your buildings, the more likely that you'll have more cases to contact trace. So you're going to make sure that you don't exceed your capacity to do it, because it can be really time consuming, especially as you get more and more people involved in these complicated webs. I think the other thing is, I imagine maybe some of the same people that doing the contact tracing are also trying to figure out which kids have symptoms and what to do with them. Respiratory season is going to start in another month, and a high proportion of your kids are going to have the sniffles. It's going to create a tremendous amount of work to figure out, are they COVID tested, are they not COVID tested? If they're not COVID tested, when can they come back? And I think you're going to have a lot of staff tied up in trying to keep that all straight. So just make sure that you have capacity to do that too. Matt mentioned this, but the trend is currently increasing in the state. We're a little bit sheltered from that right now. Dane County saw a little bit of a decrease, but we haven't been in a situation before. I think today the Waunakee systems and the Fox Valley systems announced that they're postponing procedures again. And that's a really bad sign. That means that they're really struggling, or there's no way they would turn off the thing that pays their bills every day. So that's not great news. It's hard to know what to do with the Waunakee data. I mean, you almost had like a 5-day trend there. I think yesterday might have been a bit of an aberrancy. But if you continue to see days where you have, 10 plus cases, you're looking at pretty high prevalence of disease in the community, which means you're gonna have more kids in school that will get the disease, not because they're getting it in school, but because they got it somewhere else in their community, their parents. And that could make it difficult to keep the doors open. The other thing, and we don't know this yet, but there's some speculation, early on we were like, well, it's gotta be the campuses, college campuses that are driving these case numbers. But we're seeing case increases in a lot of our rural counties. And with contact tracing, they're certainly identifying gatherings, so like weddings and things like that. But it doesn't seem like there's enough people getting married where you could account for all these cases. And there's some thoughts that, especially in these rural counties that maybe don't have the resources that a school district like Waunakee has, they probably are having community spread in the schools. The kids are doing so well with it, they have no idea that the kids have it, and it's starting to spread around the communities from the schools. That's the one thing that's pretty common across a lot of these rural counties north of Dane County, is they've gone back to in-person instruction, and we don't know, but there's a hypothesis that some of these increase in numbers could be from in-person education. We don't know for sure. Number 5, I think the one thing to keep in mind is if we bring more kids back, something that is already going really well, which is basically what you have going right now, your 4K through 2nd has been going really well. I think other school districts around here are probably looking at you as the example for like how can you do this effectively. So I think there's some risk if we bring more kids back and it does overwhelm us and we have to turn the whole thing off for a while, it's going to create some confusion in the community over whether or not you can do this successfully or not. I don't think it'll be as easy as you just turn off 3 and 4. You probably end up having to turn off all of it until you figure out what's going on and then slowly bring it back up. So I don't think you want to necessarily lose all of it too quickly unless you know for sure you can do it safely. There's this idea of how will parents respond if we need to do this touch and go. There's other communities that are doing this where they have some cases, they have to pull back, and then they go again. I think if you do that enough times, you're going to start to create a little bit of angst in the community with regards to parents wondering if the school is safe or not, because you're turning on and you're turning off all the time. And it could be totally safe, but perception could be that we're struggling to keep on top of things. And then we talked about Dane County numbers, and then this idea that we need to work probably a little bit more with our parents to make sure they know that if they have a kid in a hybrid system, it's really important to report that information. We're getting reports from other school districts where kids who don't have very severe symptoms are getting sent to school and putting a lot of responsibility on the schools to pick up sick kids rather than on the parents. So I think as much as we can do to make sure that that message is shored up is something we should consider too. So that's what I pulled out, just things to like tuck in the back of your head as you think about what is the right decision to do, balance these different things out.
So mine is I do believe that the rate locally is going up because we are certainly getting more calls and more attention. We're definitely doing a lot more people asking who they have to notify and what they need to do. Our hospitals also got busier, which we talked about. It may be, my kid came home, he doesn't live in the dorms, but he came home after he heard about it, you're like, what are you doing here?
You didn't lock the door?
We should have, I know, we should have thought about, we're not that organized. When I think about the virus itself, I actually don't think about the kids as being, I do know the kids can get the virus, but I don't, because I live in the community, I'm more concerned about the secondary effects, which is the grandparents that live in the town, and because the grandparents are doing a fair amount of the home teaching right now. So there'll be one kid comes home, one kid goes to school, and grandma's helping teach. It's not an uncommon scenario now. I'm not saying that they're getting sick at this point. As I think of the kids going, I think of the secondary spread, not the primary, the kids themselves. The kids obviously can get sick. They seem to be gifted, as we talked about before. We haven't hit at our personal building where we've had a bunch of illness, but we have had way more phone calls in the last 2 days than we've had in weeks. So I don't know exactly what's happening, but something is happening, and maybe just the awareness. So when I see it, I go, I really would love the kids to be in school. I think they do better there. But my problem is the secondary effects in town. And like, that person at school affects, that kid going to school is not the problem generally. The kid is that if the grandma's taking care of it, and then grandma goes see their parent, that can be a problem. So that's where I hesitate. When I saw the diagram for the openings, I was like, and I saw it with one directional arrows, I was having a little bit of chest pain because I don't think that's what you're going to end up doing. The arrows are going to go back and forth and probably up and down. And I do believe you'll be able to get those 3rd and 4th graders in. I just would love I'd love to see the surge come down. Right? I feel like we're in a local surge, and I could be that I'm just wrong about it because I won't know until. And I love your data. The data is the best that I see. I mean, that local data as far as. But I would love to see that number go back to where we were 2 weeks ago. Because I was like, well, we're going to do this. And now I'm a little bit like that. I don't want to do it now and then pull everybody out again because I think that is mean almost because they're so eager to go. So, sorry, talking too much.
I think the risk of the yo-yo is real. I think that both of you point out. And what that does, I mean, you guys know this better than we would, but what that impact is if, for 3 days you're, in person, and we pulled you back now, and, what that does for the teachers and what that does for the students, learning experience, because I do think right now with the level of community spread, that's a likelihood. I think you see that in other places around the state where you have, not insignificant spread at baseline.
I think if we had this meeting last week, I would be talking totally differently. As far as, just because we were so peaceful last week. And I think we'll be peaceful again. I just don't know the timing of it. And I know that we'll go back and forth.
I mean, when we first talked, we were all on board with K. I mean, at least I was on board with K through 4. And then the county kind of shut it down, like, yeah, kind of got it. And now it's different. It's a completely different environment where case numbers in our communities are much higher than they were when we were talking about bringing K through 4 back. And that wasn't that long ago, right?
I think to bring some context into it as well, we had looked at this back, we haven't had a winter true respiratory season experience with COVID, right? So March is really probably early April is probably the best corollary that we have. And when we had gone back and looked at some of our data before, and we have our screening questions, for patients, the number in the March, from the middle of March to the end of May, the March number is about triple. Number of people with respiratory symptoms who are calling our clinics compared to what it was, in late April. And so I would say that we were talking with some folks from the state and school medicine, public health, and people who are really experts in this area, and expecting that in November it'll really kick up. And I would guess you're probably going to have to bake in some idea of 2, 3, 4 times the number of symptomatic individuals at that time. So as you're thinking about it, if you're thinking about, what if we sent 3, 4 back in 2 weeks, you got to presume that in 4 weeks, 6 weeks after that, you're probably going to double the number of people. That rate is going to double. So you would increase the number of bodies, and then you're going to double the rate, along with that. So when we talked last time about modeling and just thinking about what is that contact tracing requirement, I think that's just the context that I would give to what does respiratory season mean. It means, tripling of your symptomatic students.
Randy, how many, if we put 3 and 4 back in, how many students is it in staff?
You're looking at 600 kids probably, but you've got a portion of those that are choosing remote. So if you follow that, it's 30% are choosing remote.
So it'll be about double what we have now.
So,
Randy, because I was thinking about this, do you know how many of them are from the same families?
Offhand, no, Bill. I mean, certainly you have, right now you have families that have 4K or kindergarten first or second grader in and a 3rd or 4th grader at home. So you have that situation that certainly is occurring. You have little kids and all the way up through high school. So you've got all those kinds of mixes, but as far as the number of kids, back to your piece, Brian, I mean, we're running right now about 30% choosing virtual. We'll see what that ends up being when they actually would move that direction. But then you would have, you're adding 400 kids.
Yeah, I guess the question I wanted to ask is if 5 days from now, the numbers keep climbing just a bit, and we double it, the number of students, do we have the capacity to take it? You know, or does it even worth it?
And I think, Sarah, I'm not
The
going to
rest
put
of
words in your
people.
mouth, your biggest concern is just keeping up with the tracing of it. And we're adding some additional staff here. That's a piece that we've got to increase on, and I think that was a conversation that as we get into this and had some experience, if we needed to, that would be a place to consider.
How have we done on busing numbers? Have they
I
pretty
think
much
that's
stayed?
gone fairly well. Yeah, that hasn't caused any angst really amongst Steve. I mean, there's certainly, if we have to, we're not having to run quite as many routes right now, so we're able to, if we have to add some buses, et cetera, we can do that. So I know that he's talked with Lamers about the transportation aspects.
Have you guys done modeling, you know, or are we still trying to figure that out? You know, we've got one student that we got to do contact tracing. You know, I know the number last time was thrown out to a half hour per student. Is that still a half hour per student, or is it longer, is it less?
So I would say for students with symptoms, some of those calls are going a little bit quicker. As staff gets more comfortable with the question, and since we implemented the script, I think that that's helpful because it helps people stay organized. But for example, I would say, you know, if we have 5 or 6, a lot of days in the elementary, I feel like we have 5 or 6 students that we need to, so not all of the students that we call end up making it to the spreadsheet either, right? Because if there's someone who's out due to illness, but those symptoms aren't specified, that's still a phone call for the health staff. And so if 5 people make it onto the tracking sheet, we maybe called 10. And, you know, the other 5 had something that wasn't, you know, a COVID symptom that was going to keep the child out of school for an extended period. So, yeah, I mean, because parents have a lot of questions, it's also an opportunity for us to educate families. You know, even if it's not even if this particular instance isn't a COVID-related illness, we're still saying, you know, these are the symptoms, we're gonna send you our information. So I would say each phone call is 10 to 15 minutes, but we haven't, you know.
Sure. I would say there's probably more symptomatic kids, not that they have COVID, but I know it's a time where there's allergies and stuff. Sure. I just got tested on Monday because I had allergies for 2 weeks. I'm negative, by the way. I wouldn't be here if I wasn't.
Right.
But just because it was lingering on and this got in my head
Right.
that I'm attending all these meetings and working,
Yeah.
that I need to get tested. You know, I know that there's community members that probably are just pushing it off as that. You know, they're picking corn and they're picking up dust and stuff. So I think, you know, we need to keep telling people. And my kid's not in school, so why do I need to tell anybody? They probably not even think about it. So I think that's a big push we need to hit the community with. We're not trying to, you know, push kids in their room. We want to know, you know, how we're doing.
And the reality is, and I'd like other providers in the room to speak to this too, just sort of like, a nurse or a health office assistant, you know, if a child is coughing and they come to you, what do you recommend? Right? If you know the child doesn't have reactive airway, and even if they do, but their cough is up from baseline, what do you recommend? And I think the community needs, you know, it's just that knowledge that, you know, it's not that we're saying that you need a COVID test because your child's in school. That is most likely, we're asking you to go to see your provider because most likely that will be your provider's recommendation because of what we know about the community spread of COVID. And so it's not that we're trying to make people jump through hoops to be able to come to school, but that is, I mean, if you could each say, if you have a child who comes to you, what do you say? Do you, what is your recommendation?
I think it's one of the hardest parts for people is they think, oh, this is mild, it's not a big deal, but absolutely, for people with even mild new respiratory symptoms, absolutely, I think the recommendation is to be tested, so.
I mean, we have a handful of stories, and it's exactly your scenario. I think it's just my allergies, but now it's been 4 days. My allergies don't usually last 4 days. I get tested, I'm positive, oh geez, who did I all expose the last 4 days? That story has repeated itself, so like the idea that, yeah, it probably is your allergies, like no one's gonna question that. I still need you to get a test, because it doesn't take very many people where it wasn't the allergies, and then we have a huge problem.
Yeah, the number of people I was tracking for those, till I found out.
Right,
Yeah.
see?
Yep, I
Well,
was like,
that's the
like
real,
15,
that's why the
16 people
real
had
value
contact.
of testing, I believe, is that it serves to prevent the third person. You're probably not keeping mom and dad from being exposed, obviously. But maybe you keep grandma or some other, but, I mean, the vulnerable being exposed because you
school
did the
staff.
testing.
Right.
Right, which
Yeah.
includes school staff. And there's school staff that can't be in school, right, because they're clearly vulnerable. So that is the one of the first things to go. That there are people who are vulnerable, and there are people who are not is likely to get ill from it. But knowing who you're trying to prevent the third exposure, like if you know the kid's got it, and mom probably is, and dad probably have it, trying to get it so it doesn't move to the next step. If mom is taking care of grandma and things like that. That is the real dilemma with this, because the people who are attending school aren't, the staff are at risk, the families are at risk. They're not the people the kids aren't the ones that are the problem.
So I think one of the things, I'm trying to figure out, how do we get kids back in school? And that's really the purpose, I thought, of this committee. We put the procedures together, we've got the process under control. The board approved contact tracer, and if you need another one, I'm sure the board is going to approve another person, to do that. And I look at these numbers, and, we're saying 75% of, the close contact was out of school. I look at the student symptoms, those people I'm hearing, those aren't in school. How do we, and yes, the numbers are going up, but is that a blip? Is that a week? Is that 2 weeks? How long do we wait? We've got people out there that are putting pressure, or at least wanting a plan on how do we get back to, some type of education. And, we can look at all the scenarios, the what ifs, but sooner or later, we got to sit down and say, how do we get these kids back in?
And mine is, I don't disagree with you, mine is that literally last week, if you just said, look at the data last week, I'd have said, this is happening, right? I mean, this is going to happen. My proposal would be that you look at the rest of this blip and see what happens. And as soon as, and I'm not going to pick the number because I can't pick the number, but as soon as I believe it will taper down again, right? And then when you hit the number we were at before, you say, we're going to go. I mean, we're going to go. And it could happen that it's not a very lengthy period of time. That's why I tease about this piece of paper, because I go, the arrows have to go both ways. You're going to have to the board's going to have to make a decision, say, once we go, we're not locked to going because we may have to retreat. I mean, so which is going to be a
I
hard.
agree with that, Bill.
Yeah, so I think if you were back, literally if you were here last week and we were sitting here, not knowing what else, just knowing the numbers that I knew, I said, we're going. And now after seeing knowing what's happening, go, hey, can we just ride this blip? And as soon as we get to the numbers that are sort of back where we were, we go. I mean, but I can't speak for everybody, but I would have literally last week said, we're going. And now with this thing, I go, God, we gotta see what happens, because it's probably just gonna circle down again. I don't want to be too optimistic, obviously, but I expect it'll go back down, that this mountain will be dropped, and then we can say, and I'm not proposing a number, but if you're at the numbers we were at before, I'd have said, let's go.
So Kurt, when you look at your larger spreadsheet, and I'm going off of memory here from looking at it, our numbers locally were higher last week than they were this week. Am I recalling that correctly?
So, last week let's start last week on Sunday, which would have been the 20th, I believe. Is that right? Yeah, I think that's right. We had 6 positives on Sunday. On Monday, we had 1. On Tuesday, we had 1. Wednesday, 8. Thursday, 2. Friday, 1. Saturday, 2. Sunday, 5. This Monday, 4. Yesterday was 10. Today is 5.
So we've collected the 2 weeks, this was really kind of our 2-week window, and that's, you're seeing only the 5 days kind of shown up here, but you've got 15 days worth of data that we're kind of tracking. And that's the part, I guess, we're trying, as we were kind of going through this yesterday, I mean, my initial inclination was that we were getting better. Then we throw some of the numbers out here on these 7 and 14-day models and trying to, you're just seeing a lot of volatility. I mean, just between your 7-day rate here, you're jumping 5 points. And trying to get kind of a sense of what number should we be looking at when you're really looking at these short windows of 7 and 14 days. And when you throw in a kind of these smaller end numbers, but a 10 throws you in a whole different, it changes your numbers quite drastically just with 1 day.
I think that you're highlighting, Jack, I mean, there's a lot of the complexity and a lot of that gray, right? So this is as much art as it is science. You know, there's a lot of science that, you know, is relevant to the discussion. The question of, you know, when do you go back? I think what you're hearing from the group is there's angst because of, you know, what's going on in other parts of the state. There's angst in, you know, a lot of the unknown. And I think there's angst in the persistent level of community spread and, you know, and those things. I think really the question that I think is before the board, and, you know, I'll be honest, I'm kind of glad that I don't have to, you know, make this an advisory committee, and I'm not the one
It's
making
way
the
better,
decision.
it's way better.
You know, is it really what level of risk tolerance? And there's risk tolerance to, you know, the impact you might have to K2 that, you know, has been successful and might be having to pull that back. Or there's the risk tolerance of, you know, the back and forth. Because, quite frankly, this is going to be volatile, you know, on an ongoing basis, you know, all winter, you know, I would guess. And I think there's going to be ups, there's going to be downs. There's also the risk tolerance that the board feels comfortable as members of the community, you know, you know, I would sure hope that nobody's gonna, you know, there's Monday morning quarterbacking everywhere. You know, let's say we put more kids back in school and the community has, you know, broader, you know, outbreak and impact. You know, we try to change, it didn't happen, but I think that kind of gets to the, again, the board's level of comfort with that risk and that risk tolerance of, you know, what's the duty to get kids in school, what's the duty to the community, you know, in promoting that safety. And I don't know what the answer is. I think that what you're hearing from us, and somebody who doesn't agree, please speak up, is it's not a slam dunk, you know, that it's safe. And I think as medical professionals, you know, our first rule is, you know, do no harm. And I think you're just hearing a bit of a, not sure how this is going to go. And there's certainly some evidence elsewhere that it, you know, is a yo-yo and may not go very well. And the state as a whole is in a difficult place. So I think we all share the goal, but I think you're going to continue to hear, you know, as long as we remain at this level of community spread, it's a little bit iffy. And so it's a question of if the board wants to dip the toe in the water and try to, you know, take that next step, recognizing it's going to probably be bumpy along the way. I guess that's how I look at it.
I think the other thing that makes your job harder is I suspect people in the community want, like, on this day, we're going back to whatever, there's lead time between when you make that decision and when the school can actually do that. And the environment could be completely different in that 1 week between when you made that decision and now when you're supposed to go live. It just gets really hard because the day that you make the decision isn't the day that it happens, and you may have made a different decision on the day that it goes live than you made a week before. And you're seeing that with some of this volatility, and you can pull some trend stuff out of there, but let's say this gets a little bit worse. You might be in a position where, like, yeah, we said we were going to do it, but now it's just a week later, and you're saying we can't. And I feel like lots of times in the public, they're like, well, make up your mind, and it's like nothing to do with making up my mind. It's like the data is changing all the time. It's really hard to pin this down.
I think what's the impact of the teachers? You know, I think as a parent, I'll take off my medical hat for a minute, I'll put on my parent hat. You know, it's, you know, what happens if that teacher is going, you know, I'm planning for in-person here, and then I gotta do virtual now over here, and what does that do to the quality of education the kids get? Because I think the presumption is it'll be better if it's in person, but, you know, if it's on that yo-yo, will it? I don't know the answer to that, and I would look to the, obviously the district, you know, folks to say, you know, our teachers can handle blank, but there's going to be tons of uncertainty. And I think that's part of it. You talk about marketing to the community. You know, if and when the board decides to send more kids back to school, I think that message of all written in pencil, subject to, you know, change, and coaching people that we're likely to have to pull back and do all virtual at some point. We're likely then to have to go back, you know, go back and do in person. I think setting those expectations up front would be really important.
All right. You brought up two big issues. One is our contact tracing, and can it handle what's going to be definitely an increased workload? And I'd like to hear from Kurt and Sarah, basically the fact that respiratory season could triple our caseload, and if we went 3-4, that doubles our caseload, so that's multiplying by 6. What will it take, based on what you've had this past week, to handle 6 times that amount of work?
Well, remember, it could be more than that, because you may have more of those contacts. What would have happened with your 20 people yesterday, or whatever it was? You know, if
numbers
those
on the
people had been in
bus.
school
Right, yeah.
together.
If we took 20
It's actually
people and said it's going to be
exponential.
120 next week,
Yeah, it's exponential.
what do we need to do?
Well, some of that also is dependent upon what's your acceptable timeline for completing that event.
All right.
If you look at public health, one of their metrics is trying to complete that contact tracing within a 48-hour period of time. If that's our goal, it's different than if our goal is, which I think we're kind of operating under the goal of same day, getting it done in the same day. Because I think the difference between what public health is doing and what we're doing is the next day we're bringing in groups of kids again, right? And it's like, I think we're operating under, we have to have this done in the day so that we can make a decision about what tomorrow should look like. So if that's the case, then if we're going to take your 120 example, we're going to need a lot more than one contact tracer to do that. The other thing that we also, again, in the meeting that we had right prior to this, is we also talked about how we're going to need to when we get this position and this new person in, it's going to change how we're using our health assistants and our nurses to a degree, because we're going to have another person in the mix. And some of what our health assistants have been doing, they'll no longer need to do, but we also have to now create a system that would transition some of their activities to this new position, so that they're not doing more of the process. So if you want me to throw out a number, I would say we probably would need at least 3. If that's what your again, it's unknown as to how much we're going to actually experience.
Right. But
Until we do.
you're saying basically we would need 3 people for contact tracing.
Well, that's what I'm thinking. I don't know what you're
Right.
thinking.
3 additional, that includes the 1 additional we're already doing. So you'd want to triple that number.
So, and we need to take into account the population of the high school. Because we've talked a little bit about, I know that they're not in person right now, but there are activities, and we do want to have them come in for chemistry classes and things like that. So as those groups grow, and if we're trying to track what's going on with virtual students in order to help make decisions about what else we can open, that student body at the high school requires 1 contact tracer alone, almost.
So we're talking 4.
Probably, I mean, we don't quite know the scope of the enhanced remote at the high school, because we haven't worked through that process yet. Because right now, we're just gathering information from the teachers about the courses that they want to propose having us bring students in for.
So we're saying if we did 3-4, we would need 3. And once the high school starts doing the enhanced remote at a class level rate, we'll probably need another one there too.
And so that's 3 contact tracers in addition to the 2 full-time nurses and the 3 health office staff.
Right.
That would be.
Okay. So the other question you brought up, and I thought about that a lot too, is about parents sending kids to school who are mildly sick, if we want to call it that. You know, they're not quite fainting. There's some version less than that, but they're coughing or whatever. How much have we seen of that in K2 so far?
I would say that people are being very good about reporting illness on the self-report. And I would say overall, many of the parents have been practicing an abundance of caution with keeping their kids home, even when maybe they don't need to. So that's been promising. You know, people don't. If no one wants to have their child spreading anything. So I would say the cases where we've had ill children who are sent are relatively few at this point.
Are you talking 1 to 2 a day at most, or something less than that?
I think that's accurate.
About 1 to 2 a day. So if we went 3-4, I would expect the parents are probably no less responsible than K2. And we'd probably be seeing about double that number in a day. So
I think that's true now, but I think we're also on the doorstep of
yeah,
cold and flu season.
so we should probably use our triple number on that and start saying you're going to see 5 to 6 a day.
And if I may, we have a number of families who may have chosen to be virtual, but one's brief because they have 1 kid in virtual and 1 kid could have come into the school. And now that both can come into the school, they're going to be sending them both into the school and the parents going back to work, where fudging is more likely to happen. If you think it might not be COVID and you need to go back to work and you have a special meeting that day, so that's something else to consider as well.
The other consideration is that a large percentage of children with COVID are asymptomatic. So,
Right. We know we're doubling our risk if we went 3-4, just as a given. So, coming back to all that, this is, I think many members of the board have different views of this medical thing. When I first talked with Randy about setting up the committee, my whole thing was about a metric for when to go back, to go to virtual, because I wasn't seeing anything from Dane County Health really saying, things have gotten bad, you need to shut down. And it's just like, well, how do we pull that trigger or when? So my whole question has always been, when is it too bad? And I everybody wants to say when it's good enough, kind of. They want to see these low numbers, but nobody says, how do you go backwards? So as we're looking at this right now, about 3-4, and the concept of saying that we were thinking last week might have been okay, and I gotta admit, for me, it's very hard to look at just Waunakee, because you look at the numbers this week of the 1, 2, 5, 4, and 10, and you look at last week's number, and they add up about the same. And I'm just going, boy, a 1 week number is pretty tough to look at. And maybe one of the things that really took me over the question of should we, my first thought was follow Madison, let's just be virtual. And the one thing that kind of convinced me that we need to look deeper than that was when you guys said you were going to send your own kids to school. And that made me realize, if they say to send the kids to school, then maybe I'm overreacting. Right now, if we opened up 3-4, would you send your kids? I know that's a tough
It's a tough
question.
question, but I think for me, and we've talked about this, is we've got this escalation in cases, and you're right, like, as much as it's great to have Waunakee data, because it's our data, the N is small enough where, like, the variability makes it hard to know what to do with it. So then you go to Dane County data, which is bigger, but then how applicable is it? I think that's where it's tricky. I'd like to see stability, or at least a trend of decreasing cases that would suggest to us that the community transmission is a little bit lower before, I'd say compared to early on where I was 100% there with both of my kids. I think we've done a nice job with the K through 2, like that's been working great. With my 4th grader, doubling the number of kids in the school with how high transmission is, it gives me pause right now until I can see where that curve is going to go. And it's not much more scientific than that. It just, with what I'm seeing, I'm just a little bit
I
hesitant.
just would hate to endanger your K2 thing that you have.
Yeah.
I mean, that's my worry, is that you're endangering the positive thing you have created, is that we all of a sudden now lose K2 because you did 3-4. I mean, and K2 is very valuable to the, I would love to see, I don't have a 3, thank God I don't have a 4th grader.
I heard it's way easier than a teenager.
Yeah, right, that just shows up, I'm hungry, I'm just hungry. But mine is that those pods, that are at home pods, I live in the community thing, like where I have grandmas, and it's not, I love that at the 4th grader goes, I just worry of the effects of the 4th grade. And to be honest, the kindergartner, but you guys have really kept it under control. And I was super impressed. I drove past football, everybody had their masks on. They were correct. They were doing what we tell them to do, and I was super impressed. So I think the people are doing the right things. It's impossible. This is a bit of art. Like he said, hey, you go back to what we had last week, I would take it, but you guys are the ones that, thankfully, you guys are the ones that have to decide.
Well, I think, one of the things that we know that this is going to be variable. It's going to have peaks, it's going to have valleys. And if we don't make a decision on going back when, we're going to go back in 2021, which is not acceptable in this community.
Dr. Anderson, what did you feel?
I'm with these. I would not send my kid. I have a 5th grader, so if it was last year, probably. I think to Bill's point earlier, I have concerns, and to Jeff's. I just feel like the community spread rate is too high right now. I feel like the secondary impact of what that might mean. I think about my patients. I think about other people in the community, and then I think the other thing, again, this is just me personally. I feel like the stability for my child at that point, of the likelihood they would be in and out, would be something that's an individual choice. I'm not suggesting that that's a reason, but I'm thinking about what I would do, the secondary impact that I think is likely to happen with the community spread where it is, and just the stability aspect.
Well, then, another issue you brought up, which I also, many of us have thought about, is the fact that even if we said we were going to possibly look at opening up 3-4, which our board meeting is Monday. If we did that, it's still 2 weeks away before we actually opened it. So does it make sense to say, maybe the board says, okay, we're going to try and open up in 2 weeks because we're all hoping that that curve drops. And 2 weeks, by then it's 2.5 weeks from now.
Yep.
That's a long period of time where 2 weeks ago we would have said open. Would it make sense to have, with the understanding that we're going to tell parents, we may pull the trigger backwards on you 5 days before we're going to open. Would it make sense to have a meeting of this group 2 weeks from now, right before we were about to open, with the idea of, do we continue or do we stop? Or is that just too...
Well, I think from the purely medical perspective, having that kind of flexibility is perfect. I think, and maybe Randy can answer, I think logistically that might be really difficult for your teacher.
That's a kill, Randy.
So if the teacher's in
Brian, I'm sure my question said
You start to sweat a little bit.
Yeah.
Don't do that.
Are you going to ask the 3-4 teachers to make 2 lesson plans for 2 weeks?
I don't, Aaron, I have no idea. This is all about what can we, what can't we do. It's not about saying we're going to do X. That's not going to happen here tonight no matter what. That takes the full board. but I just want to make sure
Right, I was
that,
talking about the board decision.
that won't be till
Would
Monday.
the board then be asking the third and fourth grade teachers to be making 2 lesson plans?
That will be up to the board to say on Monday.
And that's something we need to keep in mind, because if you say 2 weeks and in those 2 weeks they're planning for in-person and you pull the plug, then they haven't been able to plan for their in-person at the same time. Or are they going to be working 2 8-hour shifts planning, spending a day with their kids, and then the next 8 hours trying to plan for what may or may not come down the line. So we do need to look, if we're going in a direction and going to pull the plug, how we're supporting our teachers so that they can provide the quality education, because that was something that was brought up earlier, was we do need to provide enough stability that our staff can put out the product that our staff wants to put out, which is the quality that the community expects. And we also need to keep in mind that that kind of stress on our teachers is going to decrease their health and lead them to be more likely to get COVID and then pass that on as well. So we need to be keeping our teachers in mind as we're looking at these decisions, because they are the ones, on the front lines with the kids. They are the one putting the product out. They are the ones trying to be really, really flexible. And I know it was asked earlier, and it looks like the board would really like a black and white answer in a very gray world, but our teachers have had to live in this very gray world for a really long time. And to have that black and white imposed on them, knowing that it's really a gray world, is going to be a really difficult thing for them to watch. And I just wanted to bring that perspective in as well. And Aaron, feel free to add anything to that you feel appropriate.
No, they pretty much covered it.
One thing that I would encourage the board to consider in addition to all of this, and a comment, Jack, that you made, is getting kids back to some kind of an education. And I think that all of the children are receiving education, and so really looking at and evaluating how our virtual model is working, because that's, it's a risk-benefit thing, right? And what are we doing to strengthen that virtual? While we know that these decisions are really hard to make, are we really pouring in to that virtual support so that as we roll through these really difficult decisions to make, we make sure that the students who aren't coming back are getting a good education, so that we aren't under this pressure to make a difficult decision when we're not ready to make it yet.
Sarah, I do agree that our kids are getting an education. I also understand, and I've been told, that there's different learning styles.
Mm-hmm.
Some kids can make it well on the virtual, some kids cannot.
Mm-hmm.
And those kids that cannot are falling behind.
Mm-hmm.
So these are difficult decisions. We are on a roller coaster because, one instance can shut the school down. I understand all that kind of stuff. But, we also have to, keep our parents in mind, and, how do we help our parents as well? So when I look at education, it's teachers, it's parents, it's administration. When all three of those legs are running, in unison, you're going to have great education. So.
Yeah.
The piece just that I would add into that in this situation, because it's public health related, it is also community.
Yep.
And so it's the other people there in the community. I think Bill's spoken very eloquently about that. So I think it should be absolutely included in, the discussion of what that impact is going to be, because there are going to be a lot of people who don't have kids in the school who could potentially be impacted by the decisions that the board makes about the school. So just don't lose sight of that fact either.
You mean sort of like the UW?
Here we go.
I can't believe anybody would think that.
No comment.
No comment.
Close them, shut the lock the doors and let them in.
I agree with the statements, and I was kind of referring to education.
Yeah, understood.
I mean, the piece that I'm just trying to look at here is this calendar. I mean, this reality of what it takes to do this and how quickly can you flip, and respecting what Aaron and Val had said as well, as like, how do you, because there is a shift. I mean, the 2-week, the hardest group for us to bring back right now, in my opinion, is probably 3-4. And the only reason it is because we know there's going to be a shift in, and that's why we need the 2 weeks. It's the logistical piece. It's also prepping for the instruction. I'm not minimizing that. It's the parents making a decision. Just like, Jeff, you'd be making that decision, am I going to send my 4th grader, or am I going to not? And then that falls in Brian's lap with how we're staffing. So that's kind of our logistical piece, the transportation. And then it's trying to figure out, in my mind, like, at what point can you evaluate that? I mean, right now, what we were kind of laid out was meeting here tonight, board meets on the 5th. If we voted to say we're going to go with 3-4, that would bring the kids back in the 19th. What Dave and I were just sidebarring on is there a point somewhere in between that period you can kind of review the data and see kind of where we're at. It's not another 2 weeks of data, it's kind of to see kind of, I suppose it could be if you went down to the 14th, and then you're kind of flipping at a relatively quick piece of notice. That's the challenge with kind of that flip. The question that I've had is, which data point is the most important? Because we started to kind of plug these numbers together, and we were kind of putting our view to it, or I'll speak to my view of it. I mean, we really expanded this chart with 7-day averages, 14-day averages, trying to really kind of look at something that was being reported through these different models as far as the trends of how they're looking at what's occurring with regards to burden rates within a community. So, I mean, obviously the positive cases is a number we watch, but I don't know what, I mean, obviously 10's bigger than 5, but I don't know when we're trying to watch it over 2 weeks, what number are we trying to track that's given us an indication of where we should be? Because whoever said it, you're dealing with small n numbers, and you're dealing with volatility within that, just trying to do it from a community perspective. You do see that our burden rate number has gone down today just because we went from a 10 to a 5. And I see that the Dane County number's gone down from the 30, from the other chart was at like a 23. So to me, it appeared as if there was kind of a movement in the right direction from when this data was put out there. Obviously, you guys work in this field specifically on the ground every day and kind of see what's actually happening at that level. But it's trying to figure out if we come back at a point in time, in a week, in 2 weeks, what are we looking at other than kind of a gut feeling of what's kind of happening within our region?
I mean, I think if you think about that, my first thought is think about when it was good, right? So think about when we were doing really well. And not only was the absolute case volume low, but the percentage of positive test rate, I think is probably one of those. I'm thinking about some discussions that we've had related to different populations and PPE, and that's certainly been one that we're thinking about. So Jeff, I don't know what your thought is. I mean, I think the absolute case count is important, but I think the test positivity rate is a big one.
Yeah, and we have a lot of variability there. I mean, look at the 25th, we had 77 tests versus 21 on the next day. I mean, those are pieces.
Right, which is the problem with the N size, and I think then you're probably looking at it more at the
County level.
At the county level.
Yeah, I think that's what's tricky. I mean, so ideally, the most current data is the most helpful when you're trying to figure out trends, but there's so much variability that if you take 3 days of data, you don't know what you're looking at. Unless you take a bigger sample, then you're looking at Dane County, and then you don't know how applicable it is to you. Percent positive test rate is important because usually it says one of two things, both which are important. One, you just have higher community levels of COVID-19, and that's why your percent positive is higher. Or something's happening and you don't have enough tests around so that people aren't getting, you're not doing as much surveillance testing. That high number might also mean that you just don't have good eyes on what's going on. Only people getting tests are those that are symptomatic, getting tested in medical systems, things like that. So I think that's not a bad one because it kind of tells you two different things that could be going on that neither are good.
But I think, yeah, the hard thing is as much as I like the Waunakee data, it's hard to make decisions on it because you're just going to see this variability. I mean, some of this variability just has to do with logistics of testing. If you're beholden to how quickly these tests turn around, you'll see that on weekends and stuff too, where you see very low rates on the weekends and all of a sudden Monday, this huge aberration of cases. It's not because everyone got sick on Monday, it's because you're not counting Saturday, Sunday, so that's where those 7-day averages are more helpful. But then you have to have the resolution to know that the 7-day average doesn't look good because of days 1, 2, and 3, but days 4, 5, 6, 7 were a disaster.
So that's why I think a 7-day comparison. I'm trying to say, if I said, I would do what I call the delta, like this 7 days versus the last 7 versus the last 7. It sort of lets you pocket them together. Like it isn't a great, or you can do 3 days delta over the other 3 days. It's how I look at the thing. I don't look at it a 1 day individual. I look at it and say, hey, that 10 is bad. The 1 is good, but the 5 and the 5 are not so great either. So I always would just combine them. I would take the week and compare it to the week.
Yeah, and you look at this, you could say, what if we were here in 2 weeks and it was 5, the Dane County was 5%, you have 5.2, 5.0, 5.4, 5.0. You could kind of look at it and say, okay, it's stable. It maybe makes us uncomfortable, but it's stable. And then you know what your environment looks like when it's stable. And you say, we're doing okay, and this is stable, so maybe go with it. If it's 6.5, then that might give you some pause. So maybe if you look at the stability of the averages, and if it's stable and your internal is okay, then you can feel confident. You can at least project that your double number, right? And then you can ask yourself if you're comfortable with the double number or not.
I think that's a good point. So, I mean, the absolute number is important, but it's also like, what's your ability to keep up with the things that you need to be able to keep up with a certain percent positive rate? And there'd be some comfort in saying, yeah, percent positive or positive tests are 5.2% Dane County, but it's been that way for 2 weeks. You know what, 5.2%, this is the number of contact tracers we need, and you would feel confident that at that number that's been stable, you can do what you need to do to bring school back safely.
Stable or declining, right? Stable or declining.
Stable or decline, I think where it gets tricky is when it jumps around, you're like, well, at 5.2 we're fine, but now if it's 6 or 7, like we run out of our ability to do things. That makes it trickier to, put your name on a paper that says we're gonna bring kids back because you're not sure if you're gonna be able to keep up with what you need to keep up with. So yeah, some component of stability in those numbers.
I think the other thing that would make me, like we were back here, and part of the reason I think that we're more nervous is because we did see a blip on the inpatient, admissions. But the inpatient, if we came back, so I think the Dane County number had been in like the mid-20s for months. And then, what was it, Monday? It was like 38 or something like that. So, I mean, it was a big increase. We came back next week or the week after, and it was in the 40s. I would say, no way. If it's back down into the 20s, again, so I think it's, that'd be the other thing because that would be the indication that people in the community, people who are more vulnerable and at risk are being hospitalized, and it's a stressor on the health system.
Well, I'm assuming here in the next month, our total negative cases will go from like 47 to 150 because of flu season and cold season. More people are going to question it like I did.
Right, yep.
So it may produce a little bit more positive cases as well.
And it might give you better data because you'll have more people who want to keep getting tests, and you'll have a bigger pool, or maybe some stability in that, but those single-digit things, it's hard to know what to do with it.
That's your in-person.
Right, you can see the little
You can see the blip that we're talking about. The ICU patients have not increased very much at St. Mary's.
But you look at like in a week and a half's time from 17 to 37. And again, we can handle that, but it starts to get more problematic. You start getting up into the 40s, and I think that becomes a much bigger problem for the hospitals. Again, not that we can't handle that, it's just it becomes logistically, and it would, I think, give you pause.
You start shutting things down. Which is
hard to know.
Yep. you end up shutting down communities again, which is terrible. It gets to be the problem isn't just you. I mean, if you start shutting down a community because you set the school on fire, I mean, I'm teasing, but if there's too many cases in a school and you shut down the town, it gets shut down, that's worse, right? I mean, so it's not a one-layer problem. I would feel a lot better if, mine is that the hospital rate definitely went up and the community rate definitely went up in the area, and that's my issue. And I want it to be, I would love the kids back in school. I think we all hate the virus.
Second that motion.
Yes.
I hope pizza's from that word.
It's not quite as strong as we're, yes.
Is there anything else?
Yeah, we do have another item yet about flu shots. The idea about the school district getting involved in getting flu shots as a way to get down our, well, non-COVID related cases in order to reduce our contact tracing and everything. I saw a Connecticut school district, my sister lives in Connecticut, she said to me that they're basically doing it. They had staff who volunteered on weekends and stood outside of the school, and people drove through, and they were giving away flu shots as a way so the school district will have less of a problem. She then sent me a Facebook page of the parents' comments about this, which was, as we wildly know on any vaccination concept, from one extreme to the other. You did not provide them a full list of all the ingredients in the flu shot, or whatever. What would be the viability? What would be our problem? Should we even go down this road?
I think your other question you posed to me, Dave, was what about the kids who just don't have access to health care?
Right.
That you and Chris have kind of looked into that with some of the social workers. There are some resources in the county that do provide for that.
Yeah, the county is now opening up lanes at the Alliant Energy Center specific for that purpose. Again, that's great if the family has transportation to get to the Alliant Energy Center, because we don't have public transportation in Waunakee. So for families that transportation is a barrier, that's not an option for them. But there is an option within the community or within the county through Alliant Energy to do flu shots for families who are not able to, that don't have insurance or who are on Badger care. But that also doesn't serve all of our family, community members, because some of them don't have access to transportation. So we have posted that information about the Alliant Energy Center on our websites under our student services link, so that people know that it is available and how they can go about doing that.
Part of the issue would be, can you acquire it at this point? So we order flu vaccine a year basically in advance. We did order some extra a couple of months ago in not nearly the same quantity, and I imagine, I guess I don't know if public health would give it to you, or, but I think you're likely to be able to get it from Sanofi or, whomever else is probably challenging, but yeah.
Well, I would assume if we did try and do it, we probably would talk with the county about getting, even if it was something about a limited amount for a weekend, that it would relieve their Alliance Center. Right. Maybe part of that supplies away, but I guess my bigger question is, medically, should we even go near this, or is this something we should?
So medically, it's easy, absolutely. Medically, you should go near it. It's going to decrease the number of kids who've got symptoms. It's going to save you FTE and effort on your contact tracing. The difficulty is public perception. So half the population, well, not half, but some people are going to fight you on it. And then the logistics of it. So who's provided the vaccine? How are you giving it here? How is it documented? How does it go in? But from the medical aspect and the ability to keep your school running, like, it's a no-brainer, absolutely. You're trying to do everything you can to get every kid here vaccinated for influenza this year.
Slam dunk, and totally agree. And it's just a matter of logistics. And if people are upset, because you're not forcing anybody to do it, right? Mm-hmm. You're making it available to people, as what we would recommend as the right clinical thing to do.
Is there a liability issue?
No more than any other, medication administration that Sarah does on a day-to-day basis.
Yeah,
it's a standard care.
Really low, so that risk is going to be tiny.
what time window would we need to have this probably done by to be effective?
Sooner
Sooner the better.
Yesterday.
Really good day.
That's great.
Are there any partnerships between the UW and SSM? I mean, that's for you guys kind of to be able to kind of deliver that to, and are there ways to kind of work with the clinic and work with?
One of the organizations probably has, I mean, you also have facilities and things that are yours. I mean, we'd have to sort out which sites I could talk.
Couldn't you use the wellness clinic?
That's what I'm talking
what
about.
he
You
was
have,
talking about.
you have facilities that are possible. It's just a matter of, I have a little bit, I apologize, a little bit of a headache because even doing these things at the clinic can sometimes get, you have to get the right people there. You have to have, you have to have some sort of adult there with the, the whole process. It's not impossible. It is not. And documentation, right? I mean, getting documentation into files. It would be nice if both systems, because most of the patients are in one system or the other. You just say, you had this done, you had this done. There would be, again, it would involve a little bit of chatting it up.
Yeah.
Yeah, I think
I do think your idea, though, where you engage public health and you say, you know what, you guys have to do this anyways. We know that you have limitations and getting people to where you're trying to do it. We'll help you out with your job by saying, hey, we can use the school. Maybe we provide some of the people to help, but you bring your people, you take care of the documentation. But we'll help you as a public health department be more successful in getting the county
I think
vaccinated.
that is the best, is because they have the documentation status. Right?
And that would be something too, where you talk about this with other schools too, and you say, you know what, like, we have this space, we have some people who can help. It helps us as a school, it helps you as a county. Let's partner on this, and then we have more flu clinics based out of our schools, which is going to increase the number of kids vaccinated.
And if nothing else, it also pushes the whole reason why we're doing it, which might help with our education on the other parts.
Because I think there's synergy there. I mean, they want to get people vaccinated.
Sorry to bring that up, Randy.
No, that's okay. We can connect them with public health and see kind of what the options are. Then we certainly have connections there between Kurt and I. We can coordinate on that. Before we kind of adjourn here tonight, what I want to make sure, we have a board meeting on Monday. So what I'm looking to want to do, obviously some of the data pieces are important for us, and the up-to-date data pieces are going to be important. Some of this we'll get another data snapshot from the county. Problem with that is it's a week old.
Right.
So there are some things I believe we can do by going to the public health website to kind of bring in kind of what they're, at least we can extrapolate it out and try to bring that best data forward up to the point of the day on October 5th. It at least gives us another snapshot of the data. We can review that with the board on Monday. So that's kind of what I'm thinking to do from a data perspective, just to kind of follow up with what some of your pieces are as far as what's important to be tracking, and to see kind of where we are just even as we update those going into the 5th.
So we need to set about future meetings. And please understand, we have 7 board members who are going to make a decision on Monday. I cannot fully predict what that decision will be. And I would love to give the board as much versatility as possible. I would love to use your system of we can make a decision the day before we open the school. I don't think that's going to happen. But I would like to give them as much versatility as I can. So I'd like to propose setting up 2 dates with the possibility we may not do one, depending on what the board decides. I think if the board wants to try to open, our best viability would be to have a look at this data by this committee on next Friday. Would be the furthest we could go, because then that would put it right before the Monday board meeting, the next Monday board meeting, that would allow them to reverse the decision or go forward if you guys think things are looking better. That's a week and a half away.
Could do it before the 12th.
Right, so we would do it on Friday the 9th.
Could do it on the 12th.
Oh, we could do it on the 12th if we did it at like...
We just put a closed session, do it right at 6.
Oh, do it as part of the closed session instead? We're just looking at the
Do
data.
it as an open session, but do it at 6.
Would you...
Close session.
Right.
Once you move to closed session.
We could do it at the end of the meeting, like we always have in the agenda, but never use. Would Monday at 6 p.m. work?
This coming
on the 12th? No, not this coming Monday, the following.
Following Monday, the 12th.
That would give us a week and a half, or almost 2
I
weeks.
think your thought is, Dave, if we make a decision on the 5th,
If they decide to go ahead.
go ahead, then you kind of have a data snapshot review on the 12th and have some conversation.
And that would be the point to say, no, it's bad, we should stop, or no, go ahead. Because most of the first week is about getting the data from the parents of who's going to send kids to class. And it would still give the teachers a full week before anything would happen if they had to go the other way.
And they could even if you didn't, we can talk about that.
Right. Would everybody be fine with 6 p.m. on the 12th?
I won't make it because I'll be in the middle of a wilderness area in Colorado chasing elk, but.
Oh, we could zoom you in on your phone.
Well, we can't.
We can just go in. We'll just go in.
I'll have a.
You got room for another?
But Matt sees a lot of the data that I do, like, I don't know that we can see things too
I'll
differently.
call Jeff every night as.
You can text me.
Like about 4:30 in the afternoon.
Just call
Be
me.
like, hey, what are you doing?
No, you just say 3 out of the 8 points is enough to cover it. We don't have to get all.
Yeah, right.
That's what I get for hanging out with him.
Yep.
So we'll we'll have a meeting for the 12th. If for some reason if the board decides not to go forward, we will obviously notify everyone and just cancel that meeting. And then, based on the next point of consideration anyway, would be
November 2nd.
November 2nd.
Trying to move them to Mondays if that works. I mean, that just kind of lines up better with some of our board work and kind of allows us, if things are good, to kind of move things at a quicker pace.
So the November 2nd meeting will happen no matter what. So that again would be 6 p.m. on a Monday. And the November 12th is, we'll put it in our calendars for now, and we might
October
cancel it depending on what the board does next month.
So October 12th and then November
October
2nd.
12th, I'm sorry.
October 12th, November 2nd.
That's totally fine.
Yep.
And if that's good, then motion to adjourn. Is there a second?
Second.
Right, Brian. And all those in favor say aye.
Aye.
All those opposed, you can stay here and discuss medical things.
Thanks, Aaron. Thanks, Val.
If I get my elk on opening day and then pack it out on Sunday, there's a chance that I can find it.
Are you going with the guy?